Hello everyone. I trust that you and your families are safe during this time. As we all know, we are still on lockdown, therefore, the tests are still being provided online. After watching this presentation, there will be questions for you to answer. And if you have any questions regarding this presentation, my email address will be available at the end of the presentation. I'm so pleased to speak to you about home visits, a topic that is close to my heart. I hope you'll find it informative and interesting. So let's get right into it. I thought it would be great to start off with a simple definition of what a home visit is. When I searched for it online, the medical dictionary defined a home visit as a visit made by a health professional to a patient's home, usually with face-to-face contact between the health professional and the patient, less commonly between the health professional and the patient's family. Home visits are carried out by the medical staff, GP, nurses, and allied health professionals. Home visits by hospital medical staff are usually initiated by the hospital or the patient's GP and are termed um, domiciliary con- consultations. When looking at the role of a physiotherapist, we are going to provide a service and we always remain as physiotherapists. So therefore, it's important to remind ourselves of what our role is. We are care providers. We provide the necessary healthcare services to patients. As a communicator, we liaise with other members of the medical team and the multidisciplinary team. We are also liable to communicate with families and other relevant stakeholders. When going out to the community, you are also a community leader, meaning that the family and neighbors are looking to you for insights regarding health-related issues. Therefore, it is important to educate the patient and the family as to what your scope of practice is. Being a decision maker and manager mean that you are responsible for guiding the patient to achieve the goals, and you are also liable to ensure that you provide all the necessary information and devices to facilitate recovery, and you manage the appointments and the appointment time and what is going to be done in each session when you are with the patient. You are also liable to decide or to manage what the patients need and when they need to be either discharged or referred further. When looking at the HPCSA guidelines, there are no specific guidelines for home visits for the physiotherapist, but I want to emphasize 2 points. Firstly, it's the point of being professional. You have to be professional at all times in the way that you look, talk, and conduct yourself. Even though you're not at the rooms or at the hospital, the fact remains. You are still a health professional and a physiotherapist, and you're going to render services. Therefore, the same professionalism is expected at a home visit. Secondly, set boundaries. The boundary comes with the rule, and it's important that you stick to them so that the patient can also be able to follow it and not get confused. This is very important because the family and the patient could easily mistake being friendly with being friends. For example, we all know when we grew up, we were taught to be kind and to be respectful. So when refreshments are offered, which is something that we usually experience during a home visit, you'd rather ask um, for them to, or accept, you'd rather accept water, juice, tea, and biscuits rather than partaking in a full meal or any alcohol beverages, because this could easily blur the lines and deviate you from the purpose of coming to the home, which is to render physiotherapy services and not to socialize specifically. The advantages of the home visit are that one, the patients tend to learn better in a home environment. A review by Mayo that looked at stroke rehabilitation at home mentioned that the home visit encourages patient involvement and it calls upon problem-solving skills for the patient. Number two, the therapist is able to improve or include any caregiving education that is necessary for the patient to be able to carry out the necessary exercise program and home program that is specified. The family is also able to take charge of the care. It also promotes overall health and well-being in old age. For example, the therapist is able to assess the environment and make necessary changes to the environment to prevent falls for those that are staying in old age homes or those that are staying with other family relatives and they've got fragile patients or family members that would easily be susceptible to have a fall. And lastly, the therapist is able to set patient-centered goals more accurately, since the patient's environment will give you more feedback in terms of what the patient's needs are and what will facilitate the treatment. It makes it more easier for you to sit down with the patient and the family or the caregiver to set goals that are more easy, attainable, and it assures you to reach that outcome that both you and the patient are looking for. Looking at the disadvantages, one, the financial implications for both the therapist and the patient. For the therapist, they have to use their own transport, and this could be more costly for them. This also means that the therapist is taking time and resources away from the hospital or the outpatient practice by spending more time on the road. This is why it is important to ensure that you don't jeopardize yourself and the practice by traveling too far. The patient has to pay more for a home visit compared to when they are seen as an outpatient. When billing for a home visit, a 903 is used for each session, including the treatment code, which isn't the case when the patient is seen as an outpatient in an outpatient practice, where it's just the treatment codes that are billed after the initial visit. The billing is usually processed by the receptionist, so avoid accepting any cash. Another factor is the environmental factors, such as limited space to treat the patient, due to the living environment. Sometimes the patient's living environment is too confined for you to be able to treat sufficiently. Things such as noise and other family members or children could also interrupt or distract the treatment session, and this could impact on the time that you have set out for that home visit. Therefore, ensure that you identify any distractions before the treatment starts so that you can save time. Also, calling the patient 15 minutes before you arrive and asking them to prepare for the visit can avoid such interruptions. Another disadvantage is safety. As we all know, South Africa has a very high crime rate, and as a therapist, you can never fully guarantee that you'll be fully or 100% safe when you are traveling from the practice to the home visit, and especially when it's an unfamiliar neighborhood, you can never guarantee that you're going to be fully secure, and the patient will also be restricted or limited in protecting you since they are also at home. So if you don't know the area before you go for the home visit, make sure that you research the neighborhood and ask the people that have been in that area in terms of how safe it is for you to drive by yourself. Because at the end of the day, we have to come back safe to our families and our loved ones. And lastly, the lack of motivation can lead to poor outcomes, and therefore it's important to keep empowering the patient and refer to a psychologist where it is indicated. When preparing for a home visit, the therapist needs to gather all the information regarding the condition, location, payment method, and the living environment and the arrangement um, of the living environment. And most of the time, since the call will go through our receptionist, we are very privileged to know that we can gather all that information through our receptionist. So therefore, it is important that when going or arranging for the home visit, we gather all that information that was provided to the receptionist and see what is missing before you go to the home visit. For example, you need to make sure that you are aware of what condition the patient has so that you can prepare accordingly, bring the necessary equipment and tools that you will need or assistive devices that you will need for that session. If again, going back to the safety issue, if it's a place or area that you've never been to, look um look for more advice and ask questions and make sure that when you set that appointment and you confirm it, it is after you've organized all this information and you're fully aware and you're not going in there blindly, not knowing what to expect. This will also help you to look more professional and not be thrown off by anything that you will be presented with. Another thing that you need to be aware of is that you need to ensure that both you as a therapist and the patient need to be fully aware of what to expect. When the patient is asking for a home visit, they need to be briefed as to what services are provided and what cannot be provided. Because you'd find that at times when you go to a home visit, the patient, if nothing was explained to the patient would expect you to, for example, also treat or give advice to family relatives that you didn't prepare for, because they will use the the fact that you are there as something that they can take advantage of and ask you to treat another patient that you were not prepared for. So if they know exactly what to expect when you are there and you also know what the patient expects of you, you are able to also guard your goals and go there knowing exactly that when you set the boundaries and the rules, no one is going to be offended because you were open and upfront from the get-go. And lastly, I will still emphasize this: be safe. Only go to a home visit when you feel that you are safe to drive there by yourself and when it is safe to enter and exit the home environment um, after you have been with the patient. Because it's not all the time that we can actually ask the police to escort us to the home visit and back. So once again, be safe at all times. If you know that you are seeing a patient with um, maybe CRE, carry gloves and protective gear so that when you see the patient, you are protected and you do not take that home or back to the practice. Now, just looking at the COVID-19 precautions when going to a home visit, you need to screen the patient and the patient's family members under the same household before the visit, using the updated questionnaire. If you or the patient or the patient's family member has any symptoms, the appointment must be cancelled and the person needs to be in contact with their GP and self-isolate for 14 days. You need to use the COVID-19 PPE gear, and remember, we are allowed to charge for this when we are billing the patient. Ensure that the patient is wearing a mask. Since you also will be wearing a mask, it is compulsory that the patient that you're treating is also wearing a mask. Carry an alcohol-based sanitizer and disinfect your hands, the patient's hands, and the surfaces and area that you'll be using to treat the patient. Wash your hands with soap and running water before and after the treatment. And lastly, where you can, minimize constant contact. I'm very aware that as therapists, most of the times we are using our hands and in direct contact with the patient. But if it's exercise based, um, if the session is based on exercises, just try to minimize your contact when you're facilitating different exercises. Now the question comes, who should be seen for home visit? Mainly, just to sum it up, chronically ill patients who have restrictions in function or mobility, any physical limitation or other factors such as fatigue and transport problems are the patients that should be seen for a home visit. For example, this mostly incorporates patients that have neurological conditions and sometimes chest patients and geriatric patients. And with this, if it's someone that is able to come to the room, but for example, they are late um, and couldn't come during the working hours, just make sure that you don't put yourself in that position where you're providing and using resources unnecessarily to someone who really doesn't need it and is just asking for the services for the sake of the fact that they could either afford it or they couldn't arrange it on time. Only preserve the home visit for those that really are in need for it so that both the practice and you can benefit and the clients will also benefit from the whole arrangement. The number of sessions that should be provided from a home visit is determined by the physiotherapist and it mainly depends on the needs of each patient. The same way that we would um, decide the number of sessions that patients would receive in an outpatient practice um, or in the hospital. In the same setting, we need to plan after the first session how many more sessions would the patient need and how many more sessions would and how many intervals. Is it once a week, twice a week, or um, once in 2 weeks? That's all dependent on the patient needs and your initial assessment. When to discharge a patient is a very tricky question that most of the time is mainly dependent on if it's on the doctor, if it's a hospital setting, if it's in a outpatient practice, we decide that. But when it's a home visit situation, it becomes a little bit busy. So I just want to remind us of, in general, when we discharge a patient. The patient is discharged when the patient or the carers are confident and safe to carry out the required program without any supervision from the therapist. When the treatment goals and expected outcomes are achieved, and when physiotherapy does not benefit the patient any longer. At the end of the day, we do plan, for example, to see the patient. If you had planned to see the patient for 6 weeks consecutively, you find that during the fourth or third week, they're doing well and they don't need you seeing them more often. It is more than acceptable to say that, to explain to the patient that they have reached the goals that you had expected and you see fit that they can now continue by themselves and they are able to continue with their daily functions and everything without you consistently coming to see them. There is a sense of dependency at times, so at every session, just keep the patient on the loop with regards to where their progress is, when you are planning to discharge them and where they are with regards to the goals. You don't want to come um, during the session when the patient is expecting two more sessions and you come during the week and you tell them, okay, this is the last time that I'm seeing you. That will interrupt the patient's progress and um, the patient's emotional state at times. So it's very important that you're always keeping them updated about their progress and what your plans are, what you want to change and what you want to um, omit. The second message is identify the patients requiring home visits. Ensure that both you and the patient is well informed with everything that has to do with the treatment, payment, and also when you're planning to discharge, what your goals are, and the progress of the patient. And lastly, in all that you do, remember to be professional and safe. Always do what's best for you and the patient. Now, I want to summarize and discuss the article with you. I chose this topical review titled Stroke Rehabilitation at Home, Lessons Learned and Ways Forward. This is by Mayo. And I chose it because it pulls all the evidence of when home visits are introduced, or when home visits were introduced, and how effective home visits are. And even though it's not from South Africa, but it's still very relevant since there isn't much research done in South Africa regarding home visits. The aim, the aim of this review was to summarize what lessons have been learned from clinical trials evaluating the effects of providing more than one aspect of stroke rehabilitation in the home and in identifying promising avenues for implementation. The hospital at home became an attractive option in response to in response to the demand for acute care hospital beds by the 1990s, after there was the recognition that not all care has to be institutionalized. Hospital at home was tested for acute stroke patients in Italy in 1997. The hospital at home approach focused on early discharge from acute care but with support for ongoing recovery, providing rehabilitation and other services in the community setting. The home rehabilitation for stroke is under three broad rubrics. One, early supported discharge model, which is abbreviated ESD, and number two, rehabilitation at home, and number three, home exercises. I'll be discussing the evidence under these three subheadings. And with that, I just want you to keep in mind that all of the evidence has been in a way mentioned in the presentation earlier. So I will start with ESD. Systematic review found that a reduced risk of death and dependency shortened length of stay by an average of 8 days. Favorable effects on extended activities of daily living, and there was more active ESD for people with low disability, and that may be the way forward. The study by Norden and et al. Summarized the expectations of patients with respect to ESD. The patients expected support and they, so that they could manage and feel safe being at home, and for the rehabilitation team to facilitate the recovery of independence and of pre-stroke abilities. They also expected to learn different strategies to deal with these challenges and to create a new everyday life. At this point, I'd just like to make an example to what could be more familiar with us. I'll use the subacute step down as an example. For acute care, the patient is usually in a normal hospital setting, and then for further therapy, they are referred to a step-down facility where they get rehabilitation every single day. And in that setting, there is there is also a multidisciplinary team approach being implemented. A physiotherapist, occupational therapist, social worker, and GPs are available for the patient on a daily basis. The nursing care and the nursing staff is also there to facilitate that progress and recovery for the patient. When the patient is fit enough to be discharged, usually the multidisciplinary team have a meeting to discuss whether further implementations are needed when the patient is discharged home or at a care facility. So looking at the point that was mentioned now within the ESD, you already see that after a few weeks of treatment, it is then discussed when the patient can be discharged and where the patient can be discharged. Usually, working together, the team would ensure that they meet up with the family and the caregivers to prepare them for the discharge, so that when the patient is discharged, they are fully confident and aware of what is expected to them. From there onwards, the team usually organize home visits rendered by mainly the physiotherapist and sometimes the OT to continue care and to help the patient and the caregivers to adapt to the home setting. The therapist in the subacute would usually give a home program for the patient to follow in order to maintain what has already been achieved during the weeks that they were in the rehabilitation center. Thereafter, it is the job of the physiotherapist or the occupational therapist during the home visit to actually maintain and improve what was already achieved and attained in the rehab center. It is easy then for the physiotherapist providing the home visit therapy care to then see what else is needed to be added into the program in order for the patient to be more independent and to achieve the goals that were put in place when they were still in the rehab facility. Now I will move on to the second point, which is rehabilitation at home. The article mentions that rehabilitation at home helps to free up room in the rehabilitation facility for those who need the care venue. This means that the therapy team would need to spend much time on the road, taking away the resources from therapy. A 2010 synthesis by Zinhle and Mkhize showed that 4 trials found no difference between home and outpatient care. The remaining trials in the study showed that greater benefit for home rehabilitation in terms of there was greater benefit in terms of the home rehabilitation with regards to cost, satisfaction, and caregiver strength. In a study published in the prestigious New England Journal of Medicine, they found that the home rehabilitation program offered as active control, now conceived as potent with exercise targeting flexibility, range of motion, strength of arms and legs, coordination, and static and dynamic balance, found that the participants were also encouraged to walk daily. This approach was found that it was better than the intensive rehabilitation approach. The authors concluded that home exercise requires less expensive equipment and its implementation requires a smaller number of staff members. Less training is required also for the physical therapist, and patients are more likely to adhere to the regime. So with this point of rehabilitation at home, I just want to bring into light that when you are providing physiotherapy services at home to someone that has already been in a care facility, they're already aware of the daily routine or the exercises they were doing on an everyday basis, on a daily basis. Therefore, it is now also required that you use those exercises to help them adapt to the home environment and ensure that you incorporate it with what they have to do at home so that they are more confident in what they are expected to do. Usually with the home visit, if the patient is paying via the PMC benefit, the medical aid usually would give about 3 months, at most 6 months, for the patient to be able to receive physiotherapy. By then, the patient is also expected to be able to be independent and functional after those 3 months that has been given. If they are paying cash, you also need to look at how long you need to see them. And during that time, as the evidence shows, that with intense rehabilitation approach, it was less that approach was less acceptable compared to the vast exercises that were given that were mentioned earlier on. With this, I would say that it depends on each patient. There are patients that will put you in a point where you need to look at where they need to be um, getting to after the rehab. If someone is aiming to go back to work, it is also somewhat beneficial to include the intense rehabilitation with incorporating the coordination, static balance, and daily walks. Because if the patient was exposed to strenuous work and being able to be active or going to the gym, doing strenuous exercises every single day, they will still long for that intensive rehab approach. So even though the evidence shows that the intensive rehabilitation approach was less accepted, you need to still look at what the patient's needs are and treat and provide what's necessary for that patient at that time. So the last point under the rubric is the third point is home exercise. O'Neill et al. Did a study comparing the outcomes achieved by two groups of people with chronic stroke, one with 10 weeks of supervised training, and that group was 38 people, and the other group with 1 week of supervised training to learn the program, followed by 9 weeks of unsupervised training carried out at home. The number of the participants in that group was 36. In that study, the authors concluded that a brief period of exercise instruction followed by home exercises produced changes in the physical function that were retained for more than a year, like a supervised program. The home environment enables a more patient-centered approach and encourages patients' involvement in the rehabilitation process and calls on the patient to be more independent in what they want to achieve. Perhaps the greatest barrier to successful home rehabilitation was lack of motivation. In a rehabilitation facility, an unmotivated patient will still receive therapy and is likely to be set along with the crowd for other activities. On the other hand, at home, this will not be the case. A recent systematic review of empathy post-stroke estimated a prevalence in the post-acute phase of about 34%. Mayo et al. In a longitudinal study of apathy post-stroke found that any degree of apathy had a strong effect on participation in meaningful activities and life roles, likely explaining in part why 50% of people 6 months post-stroke lack for meaningful activity. Apathy post-stroke is understudied and poorly measured and largely ignored in the rehabilitation process. The fifth point, I just want to emphasize on the fact that when you are treating your patients at home, look at how their demeanor is on a daily basis or whenever you are treating them. Find out from the carers or the family members as to how the patient is doing, because that will definitely impact the outcome of what you want to achieve along with the patient. And lastly, with the review, Mayo summarized and concluded as follows. Among the lessons learned, it was that ESD is effective, and another valuable lesson is that rehabilitation for stroke is so powerful that it can be offered in any setting without sophisticated equipment or technology. We also learned that without supervision, only one only about one of three people with stroke will be able to follow or benefit from a home program. We also need to implement home or community-based rehabilitation programs for those who can and will engage and benefit from it. Thank you very much for listening to the presentation. Now I will need you to answer the questions and read the article for yourself. And if you have any questions, please do email them to me. I'll be more than willing to answer any questions regarding the presentation. Thank you very much. Keep well and keep safe.